Welcome back to Healthcare Rounds, your insider access to the healthcare industry. I'm John Marchica, CEO of Darwin Research Group. I'm excited today. We've got Dr. David Carmouche, who is Executive Vice President and Chief Clinical Transformation Officer at Lumeris, one of the leading organizations in value-based care enablement. What makes today interesting is Dr. Carmouche brings a unique perspective, having led across payer, provider, and retail sectors. So his time at Ochsner, maybe we can make sure that I'm pronouncing that right. I swear I hear so many different pronouncations of that health system. Walmart Health, and today at Lumeris, where he's focused on transforming how care is delivered and financed. And we're going to talk about what it takes to make value-based care work at scale and where AI and technology fit in this transformation. So, Dr. Carmouche, welcome to Healthcare Rounds.
John, good to see you again. Thanks for having me.
So let's start out. I gave that little brief introduction, but having this sort of diverse set of experiences in the health system and retail and now at Lumeris, are there any commonalities in these experiences or what brought you here today? Anything that you can think of?
Yeah, it's funny. My kids, they talk about when I used to be a doctor, because I was I was a practicing physician for the first 15 years of my career. And then the last 15 have largely been across payer. Actually, I was the chief medical officer at Blue Cross Louisiana, and then 7 years at Ochsner, and then 3 years at Walmart, and then the last year at Lumeris. Yeah, I think the commonality. So first of all, I think the move out of practice was largely because I didn't love how healthcare worked. I lived in it long enough. I saw how patients experienced it. I saw how I experienced it. I saw how it was financed. I just didn't think it was great. And so the move was largely to try to do something about it. And what I found, and the commonality across all of those, is it's really hard to do anything meaningful from one lens. Like a payer alone, very hard to make material differences in healthcare. Provider alone, very hard to do it. Retailer who steps outside of the traditional world, really hard to do it without all of these components coming together. And so I think the commonality has been that the answer to making healthcare largely lies at the intersection of healthcare silos in some ways. And so, when you think about what it takes to be successful in leading in that environment, it's the ability to speak and see the world speak multiple languages and see the world through different lenses so that you can find points of commonality or create points of commonality or shared vision or shared success. And it's a knack. I don't know that I was necessarily thought that was a skill that I particularly had, but as I got into the management side of healthcare, I think always being able to have one foot firmly entrenched in understanding patients and healthcare delivery, and having lived in the shoes of a provider and of a physician, and then learning the specifics of the business sector that my management roles took me to, and then being able to connect those dots was really probably the thing that created the most traction and success for me. So I'd say that's the commonality across all these roles.
I wonder, fragmentation being sort of like the big issue in the U.S. healthcare system. We talk a lot about it. I write a lot about it. I wonder if one of the issues that we have is not enough Dr. David Carmouche of the world, and I mean that in the best possible way, because trying to understand all of these different elements and all of these different ways that things come together. I mean, even the Kaisers of the world, or say the older Ochsner model, where it really had that strong managed care and payer influence, or Geisinger / Reisent. There aren't a lot of those, and it's difficult to get expertise, right? People get really good at managing risk, but they don't understand delivery. And people are really good at taking care of patients. And then, of course, in the retail side, they should understand the customer experience, but all the other stuff may be challenging. In case in point, Walmart Health is no longer, as a lot of these large entities. What was the other one with Atul Gawande was part of that one? That was at Google, or
Haven.
Thank you.
Amazon.
And so it's just really, really tough to find that combination of understanding, um, and then be able to apply that, which I think, and we're going to get to Lumeris, but I think that's one of the things that through technology that Lumeris is trying to do, to be able to pull these different things together.
Yeah, I think the people side of all of this is really hard. And you're right. I do think that in some ways, when people talk about leadership, it's largely around leadership traits. It's less around leadership tactics. And I think what you're hitting on, I think, is really important. And I've stumbled my way into the experiences that I think make me an effective leader today. If you go back to when I was in medical school, I never imagined that one day I could have said, "Oh, I was leading healthcare at Walmart." I mean, somebody might have thought my life had gone off the rails in some ways, but it was a real honor to do that and to try to step outside of traditional healthcare and do something really hard. But yeah, I do think there's a lack of. So there's two things. I think there's a lack of experiences across the aisle, as it were. I think if we took a political kind of frame to it, there's no statesman, there's no one in the middle to connect, disparate factions. And I think that plays out in healthcare. And then there's a lot of self-interest. And so the reality of it, and it's not, and I don't mean that in the most nefarious sense. It's that, it's like sustainable business models require you to be self-interested in some ways. And when you look at your business in that vacuum and you optimize that business, there's not a lot of room for that cross kind of ecosystem leadership. And there's very few people who find themselves in positions to be able to do it. So I do think there's probably something, to that for sure.
So the massive 30,000 foot question, where are we today with value-based care? How would you score us, considering the journey that we've been on for originally in Blue Cross Blue Shield, and of course the managed care days? I forget the name of their program in the late 2000s that started up, but then Cigna Accountable Care, ACOs, so on and so forth. How would you score us today?
I'll give you, the letter grade would probably be C minus. The numerical score is, 1 to 10, 10 being we've nailed it. The world is all value-based care, and 1, there's 0 of it. It's probably, 4. And honestly, I think in the last few years, there's been a little bit of a pullback from a value-based care perspective. I think COVID, the pandemic, pressures that has put on the traditional financing models and business models of most of the delivery organization have made it harder for them to take risk. I think they need certainty. And in some ways, that has coincided with changes in policy that have impacted some of the CMS funded models that have largely led the way for value-based care, and Medicare Advantage being probably, poster child for that. And so I think what we're seeing is that value-based care is still more of an idea than it is a reality. It's an ideal, maybe more than a reality. And there's some flaws to it that need to be overcome. One is that it's highly, it's built on a set of activities that most providers don't view as value added. So coding and documentation and creating risk scores to drive revenues are not really part of why anyone goes to med school. Chasing multiple quality measures across multiple payers is not unimportant, but not super inspiring. And then the ability to, or the requirement to deploy a different care model to different patients, even within the same provider panel based on the payment model, is offensive. And so all of those are like headwinds from a provider adoption perspective, and from a system adoption perspective. Largely, it's a problem of being able to predict what you don't know financially. And I think most financial leaders within health systems like the certainty of contractual rates, expected volumes against historical volumes, and don't love revenue and margin being at risk for performance, and maybe not even arriving in the same calendar year or fiscal year as the activities themselves took place. And so I think, you put all of that together, I'd say it's been hard for value-based care to become the predominant model of care. And honestly, the words themselves, value-based care, have started to take on a bit of a negative connotation. It's interesting at Lumeris, which has been a leader in value-based care, that used to connect both the clinical care model and the payment model. Is the notion of a proactive care model versus a reactive sick care model, the notion of segmenting populations and intervening while there was still health outcomes and lower costs to be achieved, and then having an economic model that rewarded you for doing that. Today, it feels like out in the community and out talking to folks, value-based care is largely now synonymous with the payment model, and it's synonymous with taking risk. And I think there's a little bit of a pushback to say, like, we're not configured to be an insurance company. If we wanted to do that, we'd have reserves and we'd have insurance license, and we would. That's not what we are, and we're a provider. And so to push risk, to us, requires a lot of investment and creates an uncertain, economic future. And so it's just a hard game to play at scale. And it's been hard in my career to ever become the predominant business model that care delivery exists within.
Yeah, I mean, I like that word ideal, right? It's almost like a mindset and shifting people's minds. And I'm thinking, I'm going to go all the way back to 2014, 2015, and going to ACO conferences at the time. That was like the big thing. And the docs that were there, I mean, they drank the Kool-Aid. They were in it to win it. They were all about, however we can get there. Now, 10, 15 years later after the fact, I agree. It feels more to me like just a bunch of carrots and sticks, that it's about incentives that are trying to fix this in some way, this broken, disorganized model that we have. It's the best one we have. But when you get into it, and we spend a lot of time here at Darwin trying to evaluate these kinds of models and see how well they're performing. But at the end of the day, I mean, I can't think of another industry that's like this. And of course, it is healthcare, but I can't think of another one where we've got this cockamamie system of payments. And we're probably not going to get into it today, but I talk a lot about pharmaceuticals on healthcare rounds, which is a mess. And then you start talking about value-based care in that area. And okay, well, what if we set up this is a common one you've probably heard before. Well, what if the polio vaccine, when it was invented, if they set up outcomes measurements and value-based pricing around the polio vaccine, right? That sounds crazy. It's almost like a societal benefit, which a lot of these products are. So, well, let's get in a little bit deeper and thinking about health systems. So, like your former employer, large IDNs, where do you think that we'll just stick with the terminology, even though you said you're right, it's kind of starting to feel offensive, but where are they struggling today with kind of a value-based approach?
Was that they're shutting down their provider-sponsored plan, the Ochsner Health plan, which is a Medicare Advantage plan. So here's another failed provider-sponsored plan. And I was there when there was a decision made to get into the plan business. And, it was based on a kind of a lot of experience in managing full risk in the Medicare space, both with capitated contracts, but also through risk-bearing ACO contracts with CMS and across a large clinically integrated network of kind of affiliated community physicians. And so there was a belief that they, had a brand that was important to consumers, and they had the ability to manage risk. So why not get into the game? The challenge there was that, my read of the challenge, I've been there for a while, is that at the end of the day, any senior in the care kind of regions of Ochsner's footprint could access all of Ochsner's providers and facilities through a Humana relationship or a United relationship. And those plans typically had richer benefits, And so, like, what's the value of the Ochsner Health plan if it's not synonymous with, being the best of all worlds? If you can get the best of all worlds in a Humana plan or United world, richer benefits and the same provider network, then why would you join? And I think at the end of the day, organizations who figured out how to make that work end up ending relationships with some of those other companies in order to force folks into a plan that they feel good about, that they're involved with, that they're the provider network of choice for. And I think therein lies the rub, because that creates threat to other parts of the organization, especially with a United, right? You terminate an MA contract, they also a major commercial payer. And there's concern when you start to go to battle with some of these larger payers that the net impact to the health system could be negative, even if for the MA plan it could be positive. And so the economics, how patients flow from payer and how they're aggregated and then are presented or intersect with the health system is a big challenge. And so I think that's one. And I think what they realized probably is that, hey, look, we've built a nice provider network. We've built a lot of capabilities to manage risk. We'll just have to do it in a multi-payer environment. And I think what Ochsner has done a pretty good job of was that they've created enough risk and enough value-based care financing mechanisms that it represents a majority of the patients on a provider's panel, which then allows them to do things like change the comp plan for primary care doctors away from RVUs to panel size or performance. It allows them to not have large segments of their population that can't access care management or care coordination activities. It allows them to kind of be very clear-headed in what the role of primary care is, which is not to just be a catchment area or a catchment vehicle for patients in the community that then they just get referred downstream, that they're clearly asked to be population health managers, to take care of the community, to take care of the population. And if they build enough of those relationships, the downstream that's necessary inevitably will all take care of itself. And I think, so what I like about Ochsner, and I think they're relatively unique. I mean, if you take out the Kaisers and the Risons and et cetera, I think they're unique in that they've been successful as a tertiary, quaternary, academic medical center, and have been really good at value-based care. And I remember when Warner Thomas, who was the CEO at the time, asked me to join the company to lead value-based care there. That was my question to him. Like, show me examples in the country where there's an organization that's been really good at tertiary quaternary care and fee-for-service and is a leader in value-based care. And we just literally, other than the fully integrated organizations, we vertically integrated organizations, we couldn't name any. And so I think it just speaks to how hard it is. But it took commitment, it took investment. It also took, when I was there, creating a P&L for value-based care, because in the absence of that, we were always going to be treated as a science project, an exercise on the side. Because what our operator partners in the fee-for-service side of the business were good at is asking for resources and committing to returns on those resources. And I knew that if we were going to be treated the same way when I asked for a new analytics platform or I asked for a new care management team, like, I needed to commit to a return on that investment. And without a P&L, there's no way to really do that inside a health system. So we created one. And so we put primary care operations in it, urgent care, post-acute care, all of our population health teams. And then the revenue side of that equation was all of our fee-for-service revenue and all of our value-based care revenue. And then we were able to see over time, were we creating a contribution margin or margin to the health system that was meaningful enough to continue to get the investments that we ultimately got to build the infrastructure to allow Ochsner to be successful. So I'd say they've had a long-term view of it. It's always been important to them. They've made the right investments, and they've changed the mechanisms within the health system that needed to be changed to empower those investments to be made and for accountability to be accepted. And I think, far after I've gone, I think they've gone to even greater heights. And I know, the leaders there are, I think they really are amazing leaders. They're strong within the health system, and they're strong externally with stakeholders. And I think it takes that to be successful over a long period of time in value-based care.
Well, Ochsner certainly, the way that Darwin measures health systems always scores extremely highly. We look at different characteristics than, say, some of the other more well-known, I guess, public evaluations of health systems.
So, John, let me say one other thing, if I could.
Yeah, please.
And I'm sorry to cut you off, but
No, please.
but there's another thing that's a reality of Ochsner that I never speak about that's really important, and that is that it's the environment that Ochsner exists in. I mean, Louisiana is a poor state. 40% of the people of Louisiana are covered by Medicaid. So the payer mix is bad. It's a sick population. It's a fun population. Great people in Louisiana, great food, great spirit, but not a healthy population, 49th or 50th almost every year in national health rankings. And so Ochsner sits in that environment. And in order to be a sustainable, growing, thriving business, it's had to be really good. I mean, it's not like it's a community where you have 100,000 new commercial lives coming into the market and your blended average commercial reimbursement is 250% of Medicare. I mean, it's a state that has a single blue that, historically has owned over 70% of the commercial market. And then it's a Medicaid and Medicare state, and it's a sick state. And so to be able to be successful, not only have they had to have amazing leaders and grow and attract and retain successful leaders, they've also had to be really innovative. And I'm not sure every health system has that array of challenges that forge creativity, innovation, business model experimentation. And so I do want to say that I think it was awesome for me to have most of my leadership experience in that same state. And so to the degree that Ochsner benefited from that environment, I think I benefited from that environment. I think I say, like, if you can get this done in Louisiana, you should be able to get it done anywhere. And I think that, that was an advantage, even though I think Ochsner may view that not as an advantage.
That's a really important point. And it makes me think of a couple of things. Montefiore, right? That's Bronx.
Yeah.
And I tell this story so often because it just blows me away that as a health system, and this goes back a few years, not that long ago, but they're installing air conditioning units in places where high asthmatic rates and very poor population are, socioeconomically pretty far down on the rung. And I remember talking to a friend of mine, this was years ago at CMS, and looking at their performance, their ACO performance, and they were killing it. They were doing really, really well financially. And then you contrast that, I think this gets to your point sort of, with let's say Sharp in San Diego that had a couple of different dips. First Pioneer, and they got out quickly, and then another dip into that world, and then they got out again. And I remember talking to somebody from Sharp who had said, we're already doing pretty well. And think about that patient population. Think about the contrast in San Diego. Of course, they have their poor areas as well, but the health of that population compared to the Bronx or compared to, as you said, in Louisiana. And that kind of adds another wrinkle when thinking about this value. You can say, well, we can do risk adjustment. We can do all kinds of things to try to equalize it. But getting back to my buddy at CMS, he was saying, look, just think about the environment, the reason why they're doing so well, and maybe their starting point, and how they're doing with their ACO. It's got a really, really tough patient population, and they're moving the needle however they can. And so I don't know where I was going with that comment, man. Maybe you have a thought in that area, but it just made me think of it when you're talking about Ochsner and the environment that they operate in as an academic plus primary care kind of system. And being able to do well is pretty tough.
Yeah. I mean, I just think your examples I think are reinforcing of the point, and I do think that there's something there, and I don't know how to I've never written about it. I've never studied about it. I've never really spoken about it. But as I'm reflecting, as we're sitting here chatting, and like, what was it that made Ochsner such a great learning lab and a great place to experiment? Largely, it was the demands of the environment. And I tell you, when we were having kind of M&A conversations or partnership conversations with other organizations, maybe non-contiguous geographies, almost invariably we were talking about an organization that had a large balance sheet, that had an operating margin that was 6 or 8%. And here we are, scratching out a 2 or maybe 2.5%, maybe 3% in a good year margin, and with not a huge balance sheet, and trying to figure out why would these other organizations be interested in talking to an Ochsner. And largely it was a recognition of both leadership and leadership development and expertise in value-based care forged out of this environment. So I do think within healthcare circles, organizations that deal maybe with the extra level of difficulty, given the factors that are, kind of that we were just talking about, I think that is recognized, and organizations who succeed despite those challenges, I think, get credit for a degree of difficulty and execution that maybe some other organizations are blessed to not have to have dealt
Right.
with. So, yeah.
Right. So I wonder if also these days with technology, kind of broadly speaking, the kinds of things with pop health, kinds of things that can be measured today versus even 10 years ago. And we've gotten a lot better. So let's dive into the Lumeris model. And one of the things that was really attractive when I was looking at this before our conversation is this sort of shared risk model. So just maybe talk a little bit about the application of technology and the ability to take on risk, and the Lumeris model and how that works.
Yeah. And so I'm going to talk about it two ways. I'm going to talk about it as it's existed for the last 10 years or so. And then I'm going to talk about the kind of the pivot that's underway. So maybe they're both technology stories. They're both Lumeris stories, but they're different stories. And so I want to make sure we catch both of these. So historically, Lumeris believed that, first of all, health systems were interesting partners in that they had aggregated about 50+% of the primary care in the country. So over half of the primary care doctors today are employed within health systems. So they're aggregators of primary care. They're aggregators of lives. They're also extremely difficult to partner with. I mean, they're complex organizations. They got multiple layers of communication, multiple decision layers. But over the years, Lumeris got good at penetrating organizations, having the right high-level conversations, and creating a value story. And that story looks something like this. Like, look, we understand value-based care. We have built technology to support that. We want to deploy it on your behalf, but we don't want you to just pay us and trust that we're going to do a good job. We want to have skin in the game with you. So we feel so strongly in our understanding of value-based care and the solutions that we bring to bear that if you will partner with us, we will take up and downside risk as our economic model for working together. What we ask in return is, let's have multi-year agreements, because we're going to make an investment in you, because we're going to be an operating partner. We're not just a consultant who's going to come in, assess, and tell you what to do. We're going to actually do it with you. The second is we're going to deploy human beings into your environment. And the third is let's make the population as substantial as we can. So multi-payer, multi-population, multi-year agreements is kind of the goal. In most cases, we're the contract holder for risk. That creates a lot of advantages for health system partners because we're negotiating with the large payers across multiple regions in the country. And it'll be a surprise to you, John, to hear this, but some of the payers will sometimes say something in one region of the country that they don't do X, Y, or Z. Well, we know that in the other region of the country they did X, Y, or Z. And so I think we're a valuable partner from a contracting perspective and underwriting perspective, make sure our partners select the right models so that they can be successful. And then we've got good technology. And the hardest part of the technology was to figure out how to marry very messy, very disparate data sets within health systems. It can frequently be multiple EMRs, multiple payer feeds, and that's before you even get to consumer data that we access and purchase, pharmacy data, HIE data, et cetera. So bringing all of that data in, normalizing it, slicing it, and dicing it, and being able to provide high-level analytics, both descriptive and predictive analytics, using a lot of AI before AI was cool, was part of the secret sauce. And the applications that sat on top of that powered the activities that Lumeris performed with our partners. Amazing, great business model, hard business model, because we rely in that world that our partner is going to do the right thing. So we're taking risk, and sometimes it's asymmetrically downsided risk for us in the early years to try to incentivize the system to move faster. When you do that, you're putting a lot of trust in your partner that they're going to do the right things to engage providers, et cetera, in the actions that need to happen. What we have found is that even with the success we've had and the longevity we've had in the space, and not a lot of others have done this with health systems as the customer, it's a hard thing to scale. It's still very human dependent. When we do all of that data aggregation and we create insights, we largely hand those insights historically to human beings. Those human beings are either the care team, or increasingly there are others like population health managers or quality managers or care coordinators. And the cost and the complexity of that model makes it hard to turn a partial value share, sharing upside, but covering all of our costs and creating a margin that creates value for the company and our shareholders. It's a hard way to operate a business. And so I think our interest most recently has been to figure out how do we take advantage of modern unlocks in AI computing, large language model AI, where now we have the ability to deploy, conversational AI and agentic AI, where we don't have to turn lists over to humans. We can actually turn it over to machines to interact with patients, et cetera, is where we are today. And we've built a product, we call it Tom. It's named after Tom Dorr, who was the internist in St. Louis, who was a co-founder of the company, and who died, unfortunately, a few years ago. And he was a big believer that primary care enabled by technology was the answer to a lot of health system ills, and just never lived long enough to see that come to life. And now it is. And so we've taken that ability to aggregate data to build a platform. That's an awesome place to create a coordinated set of agentic AI services that can be deployed on behalf of primary care providers and their care teams to engage patients outside of an office visit and connect insights back into the practice in a thoughtful way. And so that's the world that I'm living in at Lumeris. I was hired to largely take my expertise and experiences and understanding of primary care, and historically what I've done, and I think what most of us have done, is said, like, don't touch the provider's workflows, like don't mess with them, like catch what they do and smooth it out. But if what they're doing isn't enough or isn't the right thing, you're not going to win long term. And I think this is very invasive. This actually changes how providers treat chronic disease, how they do preventive and wellness. And you're actually inserting a smart machine using the patient's own data and an understanding of where that patient is at any point in time in their trajectory, and then launching services that we know will improve outcomes. That is a very different game, and it's a fun game to think about, and it represents a new chapter in my career. That is, for the first time, not having to rely on humans and the change management required of humans to actually make material changes to the care delivery model, regardless of what the payment model is. And I think that's another really interesting direction. This product is being sold into anyone who aggregates primary care as a strategic asset. And really, if the payment model is fee for service or value-based care or a mix, it doesn't matter. This model is built to be deployed on all patients. And I think we're solving some of the challenges I mentioned earlier in our talk with this technology stack, and it's just been fun to watch and be part of.
So it makes sense to me. And thank you for that that explanation, it makes sense to me how you're able to do that on the patient side. But when you're dealing with these, like you say, pop health teams and these, and the clinician, the physician in the community, how do you translate using these AI techniques or Tom or whatever? How do you change behavior? How do you, or without harming, maybe even improving workflow? How does the technology enable that to make?
Yeah.
And again, beyond the simple examples of, an AI agent taking notes in an exam room or something, where that's a lot of people do that. But how do you do that, not just for the patients, but on that provider?
Yeah. So the easiest part of AI is to explain the experience with patients. So your question's a really good one. But think about, I'm going to connect the two though, because think about, for most of us, we go, so a good friend of mine just went to see his primary care doctor for his annual physical. Well, he's not in healthcare. He knows I am. So every year after he has his physical, he shows me all of his labs and said, what did he miss, right? And he has a really good provider who I know. Well, he said, so I went in this year and I only had two complaints. One, I've had more reflux than normal, and I had a couple moles. But he did all this blood work ahead of time. And so when I had my visit, he reviewed it all. He referred me to a gastroenterologist for an endoscopy. He gave me some advice on, dietary changes in the meantime. And he sent me to a dermatologist. So 2 referrals, and reviewed labs and examined me and said, you're healthy. I'll see you next year. He goes, but David, last year when I showed you my labs, my hemoglobin A1C was 5.7. And I told him, hey, that's actually getting into the pre-diabetes range. He said, well, this year it was 5.9. And he didn't say anything about it. And so the patient knew, because I had told him last year. So he said, well, wait a minute, you're going to see me next year. Well, what's my plan when I leave here to not become diabetic? And the guy said, what are you talking about? He said, well, my hemoglobin A1C was 5.9. That's abnormal. He goes, well, yeah, but I don't do anything about it until it's 6. He said, well, okay, but like a year from now, like there's a lot that could happen to me. Like, who's going to help me between now and then? Am I on my own? And the guy said, well, I'll tell you what, I'll see you in 6 months and we can check it in 6 months. And so he was encapsulating what is one of the things that's a problem with primary care today, which is when the exam ends, in most cases, most providers have no ability to support you when you leave. And so you're out there living your life, making food choices and exercise choices, and whether you take your meds or not, et cetera. And that's outside of the view. And now with Tom, that becomes part of the care model, staying connected to patients, giving personalized dietary advice, making sure that you filled your prescription and took your medicine, making sure you went to the dermatology appointment. So first of all, to answer your question, the first thing is we've got to appeal to the doctor that there's a lot that they can't do for their patients today that this technology now allows them to do, and they actually like that. Their next question is, how do you not overwhelm me with information? You can't send me a full transcript of every encounter that AI has with a patient. So we have to talk about what summaries look like. Where do they go in the EHR? Where are they presented? When do we escalate something to the provider's in basket, which is sacrosanct? No one wants more messages. So we have to during implementation sort where certain types of insights go. The most important thing though that Tom does that I think is really important, and if you're not in healthcare, you don't understand the value of this. By virtue of us knowing most things about a patient, say a patient with diabetes and hypertension, we know their labs, we know their weight, we know their meds, we know where they're taking it, like all that's in the data. We then have a partnership with Wolters Kluwer and UpToDate where we can create a contextual clinical decision support prompt for a physician or a nurse practitioner. So if John has diabetes and your last A1C was 7.2 and you're on 2 drugs at these doses with these labs, I can actually, at the time that I create a summary saying your patients have been monitoring their blood sugars, this is what they've been running before meals and after meals, their last A1C was in 4 months. And by the way, based on everything we know about this patient, they should be on this drug in addition to their current regimen based on this evidence, and put that right in your EHR workflow, where if you're a nurse practitioner, you get an AI generated prompt with transparency to where that recommendation is coming from to help clinicians think about doing the right thing. Because as sad as it is to say, the reason hypertension control rates haven't budged in the country over the last 25 years, and the reason diabetes control rates haven't really moved, and the reason that heart failure still remains the number one cause for admission and readmission is because we don't apply evidence-based medicine consistently to these conditions. And largely it's a matter of time and follow-up and insights. And I think this solution is a solve for all of that, and clinicians get it. And at the end of the day, the only other thing that's needed for success here is that the system creates the right level of rewards that encourages the physicians to adopt and be willing to redesign workflows. And that means largely moving away from RVUs to panel size and panel outcomes. And as long as the health system is willing to do that, I think most of the providers are very willing to have this smart partner join their care team. And we're seeing actually the providers actually embrace that.
Well, it just makes me think of, and I know we're running out of time here. I could keep talking about this.
I mean, we could do this. We could do like a part two.
Part two, right? But I wonder. I kind of go back to the old ACO days. I say that back to 2014, 2015, when they increase in popularity, and it makes me think of that patient responsibility component that you can enable with everything that you said, which is great, including the fact that if I get an AI recommendation on something like that through the chart, I want to see the source. I want to know where that came from so that I can feel good about it. But then how do you structure, this is a long question or one that people have tried to answer for many years. How do you structure incentives such that the patient then, I mean, your friend seeing that 5.9, he's actively engaged in his healthcare and he wants to do better and all of that, but the average person may not be. So how do you get them to move? How do you get them to respond once you have this technology and the doc is saying, hey, this is something you need to do X, Y, and Z? I'm setting up the question in a long way. It doesn't really need to be. Is how do you have patient accountability? How do you get to that place?
Well, I will come back on your show because this is just an amazing question. And here's the answer, and it's probably one that you've never gotten from a physician. And I learned my answer is forged by two experiences. One, my clinical experience, and two, my time at Blue Cross. When I was at Blue Cross, every physician forum that I represented Blue Cross in, that was what I got back. Like, hey, you're creating all this accountability around quality and outcomes and cost control. What are you going to do to incentivize my patients to do the right thing? Fortunately, that in practice, so my practice, I was an internal medicine doctor, but I was a preventive cardiologist. So actually the patients that were referred into me were largely people like who had high risk for vascular disease and couldn't take a statin. That would be a really common referral. I didn't have magic statins. I had the same drugs everybody else had. We kept a registry, and for patients referred for statin intolerance in our practice, 80% of those people ultimately took a statin. I didn't have a magic wand. I didn't have an incentive structure. I didn't design their benefit structure for their insurance company. What I had was time with the patient to explain to them the pathophysiology of atherosclerosis, to paint it in pictures and words that they would understand, which is to say, to show them what plaque looked like, to show them how plaque ruptures and how plaque can regress. And I would just say this all the time. I'd say, listen, if you had lymphoma, if you had cancer of the lymph nodes and bloodstream, I couldn't cut it out. And there was a pill called Lipitor that you would have to take every day, and it would keep your cancer in remission so that you didn't die of it. But there was about a 10 to 20% chance that you would ache on Lipitor. Would you take it? And they said, of course. Like, I said, well, heart disease, the atherosclerosis is your cancer. You've had 2 heart attacks, a stent, and a TIA. Like, and no one ever explained it to them. So I would actually say AI, taking some of the mechanistic parts of care delivery and chart review and aggregating data off the provider so they can actually spend time talking to the patient about the hemoglobin A1C of 5.9 and what that really means and what they could do about it. is what we need for an engagement. I think the care delivery system has essentially said patient engagement is not our responsibility. It's someone else's. It's a payer. And I just think and I'm not saying there's not things that can be done with gamification, incentives, and all of that. But at the end of the day, a human being who knows you and who you believe has your best interest at heart, spending 5 minutes explaining why this pill is important for you and that the side effects that you're feeling aren't dangerous, and they're certainly not as dangerous, is the most engaging thing that can happen. And so I actually believe we've got more to do on the provider side to create patient engagement than we do outside of it. And I'll keep believing that until someone convinces me that I'm wrong.
I couldn't agree with you more, just from my own personal experience. I've had now for about 10 years the same primary care doctor. And because of the industry that I'm in, I've been in healthcare my whole career, and you know a little bit about my background.
Yeah.
Oh, I play doctor all the time. I mean, I have loads of doctor books behind me, right? And I think I know everything. I listen to what he tells me like it's gospel. And, you know, we have conversations. Now, maybe it's once a year is the best that I'm going to get with him, that I'm going to have that time. The rest of the time, maybe I'm seeing a PA if I've got another reason to see a doctor. But I completely trust what he says. And I know we're not going to have the time to go much further in this area, but that butts against I'm different. I say I'm different because of the industry and because of this company and what we do. The average person, the vast majority of people, they're out there Googling, they're out there trying to find this information, and they don't have the background. They just don't, you know, and maybe they're getting educated about things. Don't get me started on vaccines and all this other nonsense. So you're fighting. I guess my point is, as a doctor or as a practicing internist, you're fighting. You're trying to have that conversation and explain, the issue with their atherosclerosis and against what they're hearing from, I don't know, maybe other podcasts or what they're getting from Google. So it's
or
like
their
this,
friend or their friend or whatever. Yeah, listen, we could spend on, literally, this is such an interesting space, and I have a lot to say about it. But you got to get the point. I think that at the end of the day, they're also fighting, the clinicians are fighting against needing to see more patients, spending less time with patients, moving, and so like there's a reinforcing set of challenges that actually make this problem worse and worse and worse. And unfortunately, patients are increasingly left to their own devices to solve for something that ideally a well-meaning, professional who understands you and knows you and has gotten to, build trust with you would do for you if they had time. And so part of the deployment of AI is to try to create time for the human moments of healthcare to still happen, because I'm afraid they're getting crowded out. And I think there's danger to that.
Well, given the time, we got to wrap it up, but I do want to do a quick little lightning round.
Yeah, let's do it.
So short one-line responses. These are some good ones. One bold prediction about primary care in 2035.
In 2035, the office visit will be the exception to the rule. Most primary care will occur outside of an office.
Most overused buzzword in healthcare today.
Innovation.
One technology that's overhyped, and then maybe one that's underappreciated.
The EHR. Don't get me started. But the EHR is overhyped. Underrated, patient wearables.
A book that every healthcare leader should read.
Well, I have to give a plug to it since it's what I'm working on, but Chat GPT MD by Robert Pearl.
Dr. Pearl, he's been on the show a couple times.
Yeah, it's a great book, and it really opened my mind to what we're actually building now. So for me, it's just the art of the possible with current technology. I think people should read that.
Finally, most influential mentor.
God, I got so many. Very lucky. I don't want to pick one. I'm going to make somebody upset. I'll go with George Karam, physician, LSU Health Sciences Center. He was the guy that taught me internal medicine in medical school, third and fourth year. He was building a residency program at a satellite campus up in Baton Rouge, the medical schools in New Orleans. I was a very highly sought after, AOA student and could pick wherever I wanted to go to do my residency. And he had trained at the University of Alabama at Birmingham, which at the time was one of the top 3 or 4 medicine programs. He definitely could have leveraged my respect for him and the relationship we had to get me to come be one of the star pupils in his new residency program. And because he knew what was in me, he told me I needed to go away and facilitated me having interviews at UAB and being trained by the best in the world. Super selfless. And it taught me that if you really want to help someone in life, understand what's best for them and make sure you're not inserting your own judgment of what's best for you and your advice to them. And he did that in spades for me.
That's excellent advice. And it also prompted one more, we don't have to call it a lightning round question, but it's one that for a while I used to ask every physician who came on the program. I'd ask this question. If you're going to give some advice to somebody coming out of medical school today, or say entering their residency program, and I bet you do give advice to folks like this, what would you tell this person if you want to give them that pearl of wisdom?
Yeah, it's just two words that I always use: courageous and convicted. You need to be courageous. You need to be convicted. So something needs to be important to you. I don't care what it is, but whether you're in medicine or not, like what you have to be passionate about what you do. If you're not passionate about the profession, then be passionate about a business application of the profession. But be passionate. And then courageous is be willing to take a stand, be willing to speak up, be willing to take on a task or responsibility that puts you in your discomfort zone. I mean, literally, I don't view myself like necessarily as the most courageous person, but like leaving practice that I had built for 15 years to move into a management role on the hope that I could help more people by doing it was courageous. I had to say bye to practice that I built for 15 years and it's paid off dividends in spades. And so I try to say those are the two things I would impart as wisdom, hopefully.
Excellent. Well, Dr. Carmouche, it's nice to see you again. It's been a while. Thanks for coming on. And I really would like to hold you to that coming back on at some point. This has been great. I feel like time just flew. So thanks again. I really do appreciate it.
Great to see you. Thanks for the forum. And thanks for what you do.
And that'll do it for another episode of Healthcare Rounds. Our guest today has been Dr. David Carmouche, Executive Vice President, Chief Clinical Transformation Officer at Lumeris. As always, I'm your host, John Marchica, CEO of Darwin Research Group, and we'll see you next round.